Welcome, welcome, welcome back, my Be Health Empowered family, to another episode of Excuse Me, Doctor. My name is Dr. Melissa Clark, and of course, please call me Dr. Mel. I am delighted to be back here with you, and we are going to do what we do each and every week, and that's give you the information that you need to make wise health decisions for yourself, your family, and even for your community. And that information is based in science and the best evidence that we have so that you can stay informed. And look, if you are joining us for the first time on this show, please make sure that you hit that subscribe button if you're checking us out on YouTube. And if you are looking at us on Facebook, please hit that like button. We greatly, greatly, greatly appreciate you for it. Now, let us get into making an amazing week for ourselves with the health topics we're going to cover today. And in order to do that, I have to have who my Be Health Empowered family knows, Mr. Wayne Bruce and Miss Lila Mays. How y'all doing?
Howdy,
Hey,
howdy. What's going on, Dr.
doing
Mel?
well.
How you doing?
Good. You know, we had to take a break last week because even at Excuse Me, Doctor, occasionally we can have some health challenges. And
Right.
we had to take a break last week, but God willing, we are back here this week.
Dr.
God made it
Mel,
happen, and
doc,
we are grateful and blessed.
we are, Dr. Mel, you ain't have to tell everybody. Hey,
What?
y'all, I
I
ate a
kept it
pickled dodo
anonymous.
bird egg. Me and Fred Flintstone had the same reaction.
I kept it anonymous. I did not say who. I just said we were dealing with some health challenges.
It was a pickled dodo bird egg. Who knew it was going to
Well,
happen?
who knew?
Who knew?
Who knew? Well, look, stay away from pickled dodo bird eggs. That's official medical advice. And
Right.
and we are just glad that we're all back here. And this is our special Howard University once a month episode that we do with the Howard University Research Centers and Minority Institutions Community Engagement Corps.
Yeah.
And we're delighted to have a very special person join us, Miss Karen Parker, who is the project coordinator at the Community Engagement Corps. So welcome, Karen. Thanks for joining us.
Hey, Karen.
Oh, you know what? You know what? I'm sorry. That's on me. Great. Hey, Karen.
Hi.
Hey.
It's good to see everyone
How are you
again.
doing? Yes,
Happy summer.
absolutely.
It's
Happy
fabulous.
summer
I have
to
a new
you.
backdrop. I've got baskets. I have Africa behind me. So
Wow. Hey,
all
that is
around me.
very stylish. We love it.
We
And,
tr-
can you just give us a brief, very brief overview of what the Community Engagement Corps does at Research Centers for Minority Institutions at Howard?
Absolutely. And thanks for having us again. We really love this partnership. So part of what we do at the Community Engagement Corps is exactly this kind of work. We keep an open dialogue with our neighbors, our close by community at Howard University, and we work to make sure that the RCMI supported research that we do here on campus is relevant to what our community needs, and we make sure that we keep dialogues open, just like what we're doing today. So we're very happy to be here. Let's get cracking.
Absolutely.
Oh,
And
let's get
one of
cracking.
the beautiful things about this partnership is we're able to draw from the vast resources and knowledge at Howard University, the expertise of the faculty as well as the alums, and have them as guests. So we are delighted to feature the greater Howard University family on this show for their expertise. So what are we getting in tonight, y'all?
Well, I have a little factoid for you. In 2022, more than 1 in 6 Americans aged 12 or older reported experiencing a substance use disorder or SUD.
Yeah, we lost so
Wow.
many African American greats to substance abuse. I just think, you know, Michael Jackson in a certain
Mhm.
way, Whitney
Mhm.
Houston, Prince, Michael K. Williams, so
Mhm.
many.
Yeah.
Yeah. And I think those examples are why so many people think of opioids when we think of substance misuse. Although those deaths, except Michael, were associated with heroin, fentanyl, or prescription pain reliever abuse, but SUD encompasses nicotine, alcohol, marijuana, and illicit drugs like cocaine.
Exactly. So we're devoting this episode to substance use disorder. And the thing is, the death rates, the disparities in those death rates from substance use disorder are actually getting worse, not better, among Black and American Indian, Alaskan Native individuals. We know that income inequality, exposure to trauma, and racism are drivers of that disparity, and that gap in what we're seeing as outcomes from individuals who use substances and have substance use disorder. Um, so we wanted to devote this show not just to understanding more about substance use disorder, like what makes people cross over from simple use of substances to abuse and compulsive use, but also really to know, if you or a loved one are having a problem, what are the resources that are out there and what's the latest in the treatment that's available. And to do that, we have two incredible guests from the Howard University family that are going to join us tonight. Dr. Denise M. Scott, she is director of the Howard University Hospital Screening, Brief Intervention, and Referral to Treatment. And the acronym for that is SBIRT, their community expansion initiative. She's also national director of a study entitled Better Together, Integrating Medications for Opioid Use Disorder in African American Community Settings. And that study is sponsored by NIDA, the National Institutes for Drug Abuse, part of the NIH. And then we also have Dr. Walter Bland. Karen, would you like to introduce Dr. Bland for us?
Absolutely. Dr. Bland is a psychiatrist and an associate clinical professor at our very own College of Medicine. He has extensive clinical and research experience in the diagnosis and treatment of substance use disorders. Thank you very much to both of you for your flexibility in joining us this evening.
Great. So we're going to start with you, Dr. Bland. So we said, our show tonight is devoted to substance use disorder. What is substance use disorder? Can you give us a definition to start us off?
So substance use disorder is a mental condition in which the use of substances significantly impair and adversely affects a person's functioning.
No, go ahead.
Okay. So in the past, we referred to substance use disorders as either abuse or dependency, but we now recognize that substance use disorders occur along a continuum. So instead of the terms abuse and dependency, we now say substance use disorders are mild, moderate, and severe. In addition to the change of the terminology, we think it will help to destigmatize and serve as a way to draw more persons into treatment. Because, as you know, to say someone is addicted or is abusing a substance can serve to stigmatize treatment for those conditions.
I'm so glad that you brought up that issue of stigma, because so many people think that use and either moderate, mild, or severe substance use disorder is a moral failing, right? What
Correct.
is it that actually leads to substance use disorder? What's actually happening physically with us and in the brain?
Well, we know that substance use disorders are driven by multiple factors. One is genetics. For example, if you have a parent or a sibling with a substance use disorder, your chances of also developing a disorder is about 50% So that's about 1 in 3 persons.
Mm-hmm.
In addition, we know that genetics play a part in another way. For example, some groups have excess or lack of certain enzymes for breaking down certain substances. For example, alcohol. American Indians have less of the enzyme for breaking down alcohol.
Mm-hmm.
Whereas Asians also have a problem with one of the enzymes for breaking down alcohol, which causes them to drink less because they get sick sooner. So
interesting. So that's almost like a protection, right? In a way,
right, almost like
against
a protection.
right,
get
against excessive alcohol use. Yeah.
Okay. In addition, if you have a mental disorder other than alcohol, other than substance use disorder, you're at increased risk for substance use disorders. For example, persons who suffer from depression, post-traumatic stress disorder, panic disorder, are at increased risk. And probably among the non-substance use psychiatric illnesses, bipolar disorder has the highest rate of co-occurring substance use disorder associated with it. In addition, we know that access and exposure has a lot to do with substance use. We know those substances which are legalized, tobacco, alcohol, marijuana, we are seeing increasing use, and that use being problematic on the moderate to severe side because of that. So, and with younger persons, we know that their peer circle has a lot to do with their use of drugs. If substances are being used by their peers, there's an increased likelihood that they too will use those substances.
Right. So it's part genetic, part biological, and part social.
Part
in other
social.
words.
And
Yeah.
one thing that we do know about these substances of abuse is they stimulate either directly or indirectly dopamine, which is dopamine is the pleasure chemical, is the reward center. So we can see that methamphetamine, amphetamines, alcohol, opioids, tobacco, they all stimulate either directly or indirectly dopamine. And because it is a pleasurable experience from it, it reinforces its use.
Right. And so if genetically you have less dopamine, right, you might be at increased risk for using or having experiences to try to increase your dopamine in your system.
And the pleasurable feeling that persons often get on their first use becomes a reinforcement or continuum.
Makes sense. Makes sense.
I have so many questions just listening to you break this down, Doctor, but I'm going to start at the beginning. Could you tell us what your role would be as a psychiatrist in assisting these folks who suffer from SUDs? And then I have 2 follow-ups because you were talking about stimulants, and I'm wondering if caffeine falls in that area as well.
Caffeine is a stimulant, and it can be a substance of abuse. So as a psychiatrist, my role is to first establish whether or not there is a substance use disorder, and if so, what is the severity of the substance use disorder. In addition, if there are medical complications that can be a consequence of the disorder, I ask questions and examine the patient and make appropriate referrals if it appears that they may have medical complications associated with the disorder. And finally, not finally, but also I assess for any co-occurring non-substance use psychiatric conditions, such as the ones I named: bipolar disorder, major depression, panic disorder, PTSD, and treat those as well as the substance use. We know that at one time, persons would say we have to treat the substance use disorder, then we'll treat the non-substance use psychiatric disorder. But now we recognize that concurrent treatment is the best modality.
Wonderful. I want to make sure we get Dr. Scott in here. She's been waiting patiently. I want to see, can you sort of start off by describing the work that you do with substance abuse prevention and intervention? And in my introduction of you, I use the acronym SBIRT and I explain what it is. But if you could tie all that together for us, that would be great.
Sure, absolutely. So I'll start with the meaning of SBIRT or acronym. The S stands for screening, the BI for brief intervention, and the RT for referral to treatment. It is evidence-based, as you mentioned earlier, Dr. MEL. We use evidence-based practices, and it is a public health approach to screen persons for substance use disorder and provide brief intervention and referral to treatment. I often say there's no P in SBIRT, but if we're providing screening, why not provide prevention information? Just like when we go to the doctor, they don't just look at us and say, hey, doesn't look like you have high blood pressure today. No, we screen and then appropriate conversation is had. So that screening is to determine if a patient is at risk for or may have a severe substance use disorder. That brief intervention, it's a conversation with the patient to help them to motivate to maybe make healthier decisions, maybe cutting down, maybe quitting or seeking further assessment. And then that referral to treatment is that active referral to treatment. So we're just not giving someone a piece of paper and saying, you can call this number. We have health educators available in the clinic and in the ED to help patients with substance use.
ED meaning emergency department.
Yes, sorry.
Yeah.
Emergency.
Okay, great.
Yes.
Dr. Scott, can you tell us what substances are included in the prevention and intervention work that's part of what the SBIRT team does?
Oh, sure. So alcohol, tobacco, marijuana, any recreational drugs, we ask open-ended questions so persons can tell us what they're using. And then, of course, any prescription medications, whether persons are taking them as prescribed or they're using someone else's prescriptions.
That makes a lot of sense. And could you tell us, let me see if I can frame this properly.
Okay.
What is the ratio of people who are screened and identified for follow-up to those who actually come back for their follow-up? And then I have a follow-up to that, which is there a reason that there might be a gap if that ratio is particularly large? And how can we work on that?
Yeah. I would say, and this is going to sound kind of weird, it could be anywhere to about 50 to 90% of persons that might follow up. And some of the reasons could be how persons are engaged when they're in the clinic or in the emergency department. We have health educators. And if there's a good connection or if there's a great rapport with the patients are more likely to follow up. And then also readiness to change. Some persons just might not feel like they're ready to change at the time when we talk with them. So those are two gaps that I could think about.
Okay. And what can we do as a loved one or a provider or just someone who stands in support and advocacy for the person who's challenged? How can we assist with maybe bringing that ratio down?
I would say mentioning it, if you feel like a person might be using just a little bit more than they might be having problems with school or work. And I often tell persons, don't get frustrated when you're talking to someone, because you might be planting a seed that someone else will water later, or someone else is watering a seed that someone else planted previously. So I think mentioning it to persons that maybe, might be drinking a little too much, or and sometimes people realize that they might be using medication not as prescribed, or using any type of drug that would affect them in their work, in their school.
Thank you.
So, yeah, thank you. So, Dr. Bland, what kind of impact have you seen in your practice when you take these approaches that we've been talking about?
It varies. As Dr. Scott said, it depends on readiness for change. What I've noticed is that persons who are self-motivated to seek treatment tend to have better outcomes. That is, they stick with treatment. They are more often willing to enter into rehab and other programs to facilitate their goal of either reduction or abstinence from drugs.
Yeah, I think that's a really important point to make, that, you mentioned support from loved ones earlier, Karen, that, it's not really until that person is ready to change. There's
Right.
only but so much that loved ones and people around that person can do until they internally, I think you use the term self-motivated, Dr. Bland, are
Yes.
are actually ready to change. You know, when I came through medical school and training, there wasn't a lot of emphasis and learning about the treatment of substance use disorder. How has that changed, and why is it important to train various types of healthcare professionals in the methods that you're talking and about substance use disorder?
I think one of the reasons that it's changed is because we now recognize substance use disorder as a medical condition rather than a moral feeling.
Okay.
And because of that, there are more healthcare practitioners that are willing to engage persons with substance use disorders in treatment. In addition, we now have medications that can reduce and facilitate abstinence. For example, for opioid dependency, at one time we only had methadone as a treatment, but now we have, in addition to methadone, we have buprenorphine, which can be prescribed by any physician and does not require the person to come to a clinic every day to receive a dose of the medication. We also have naltrexone, which can be given either orally or by injection once a month for persons who have opioid dependency. For alcohol use disorders, we have 3 medications. One is Antabuse, which is an old medication, but a lot of people elected not to use it, because if you drink on it, you become very, very sick acutely. But now we also have a medication, naltrexone, which we use for substance use, but we use for opioid use disorder. We also added it has utility in the treatment of alcoholism. And a third medication, the camprosate, which also is approved for the use of alcohol use disorder. So we have treatment available. And then we have a range of settings where treatments can be carried out. In addition to inpatient settings, we have partial hospitalization programs, we have rehabilitation centers, and specialty clinics, outpatient clinics for persons with substance use disorder. And in those clinics, not only are the healthcare providers trained in treatment of substance use disorders, they also train in treatment of non-substance use psychiatric disorder, which is often present.
Yeah, I think all that is wonderful. And I think for me, what I would love for the Be Health Empowered family to take away is that substance use disorder is a medical condition for which there are treatments, just like insulin is used to treat diabetes. There are treatments for alcohol use disorder, for opioid use disorder, and there are also other psychological therapies available when it comes to the treatment of other substance use disorders. So would love for everybody to take that away so that you know that it's kind of not hopeless or inevitable, right? If you've seen other family members in the past deteriorate or have poor health outcomes, you know, there are now new things on the horizon that are available.
I'd like to take it back to Dr. Scott, if I may. Could you tell us, please, what is the age range of patients that are being screened at Howard?
Well, at Howard, it's 18 and above. We also are implementing this at one of our FQHC's, federally health qualified centers, and they are doing 12 and above.
Wow.
They're screening persons 12 and above. And once again, the ultimate goal, of course, would be prevention and intervention. So that we can talk to persons before it becomes a huge problem. And then once it does, of course, we have that active referral to treatment, as Dr. Bland was talking about.
And I'm sorry to interrupt. If they're screening people who are 12, that means there's a need to screen people that are 12.
It's exactly
Absolutely.
where I was going.
Absolutely. Yes. Most definitely.
Wow.
I'd like to take the discussion to what's probably an elephant in a lot of these rooms. Marijuana. It is legal in DC. It is legal in a lot of jurisdictions. And I'm curious as to what effect that is having on the number of people under 18 and under who are being identified as needing treatment for use of cannabis.
Yes, it's definitely increasing. I think Dr. Bland might have mentioned that at the top of the show. We are once again trying to encourage persons when they come in to treat marijuana use just like you would treat alcohol use. Because a lot of times persons will say, oh, well, it's legal now. But we'll say, well, yeah, alcohol is legal, but you still want to use it in a way that is not hazardous or harmful. You don't want to go out drinking and driving, using marijuana, drinking and driving. But with the young persons, yes, marijuana is increasing. And we know that, I think Dr. Bland might have mentioned earlier about the brain development in young people. The brain is still developing up to the age of 25. So persons that use marijuana and alcohol, it increases their risk for having severe substance use disorder. And also it can cause harm to the brain.
And there are studies where it's been shown that chronic use of marijuana in adolescents is a risk factor for developing of severe chronic psychiatric disorders such as schizophrenia.
Wow.
So it is not a benign substance, as Dr. Scott said, although it's legal. It
Right.
can still be harmful.
Depression and social anxiety, I think I might have been also, Dr. Glenn.
Also those two.
Which is interesting that we also are seeing the rate of suicides, death by suicide going up, the rate of depression going up in teens and young adults, coinciding with this increase in marijuana use. You know, is it the chicken or the egg, right? I think is one of the questions that we have to wonder.
Well, the other chicken egg question that I have, I think we touched on it just now, was do we think that there is a disconnect, if you will, between the legality of the substance and people just not realizing that because it's legal, that it is also addictive? They're not realizing that.
Absolutely.
I
Absolutely.
think there is a disconnect.
Yeah. What can we as health professionals do? You know, from an education or a policy standpoint, you know, given that the train it has already left the station in terms of, you know, the move towards legalization, the next step is, you know, federal legalization. What's the role of healthcare professionals in that, in helping to educate the public?
I think one of the roles of healthcare professionals is educating the public.
Yeah.
Programs such as this serve to put a spotlight on the potential consequences for use of legalized as well as illicit substances, that they all have a risk of causing adverse effects on persons' mental as well as their physical well-being.
Yes,
Right.
I agree. And realizing that as far as marijuana use is concerned, about 3 in 10 persons may develop marijuana use disorder if they're using marijuana. So
Wow.
education is definitely the key, and realizing that if persons are, you know, maybe drinking and driving or using marijuana and driving, that's hazardous use and it's harmful use. And understanding that at-risk use, when you're at an at-risk level, there's a chance that you could reduce your chance of becoming addicted to the disorder, to the disease.
Could you
Right.
repeat that stat, Dr. Scott? You said 3 in 10.
Mm-hmm. Yep.
Yeah. So that's amazing. So for every 10 people that are using marijuana, 3 are at risk for substance use disorder associated with marijuana.
Severe.
And I think that's important too. Again, a message to take away for the Be Health Empowered family is, you know, as adults who I know are indulging and using marijuana for pain control or recreationally, that it's important to realize that, and also important to let young people in our lives know that risk as well, right? Because, you know, people can say, well, do as I say and not as I do, but if you're doing it, you're patterning it for those around you who might be more vulnerable to its effect. So I think that's important to keep in mind. So Dr. Bland, you know, as an emergency physician, you know, I treated a lot. I mean, I can't even quantify, hundreds probably of people with opioid use disorder. The practice was to discharge them when they were stable. So we would, you know, treat them with Narcan, revive them, make sure physically they were okay, they didn't have any other medical problems going on, and then discharge them and instruct them to follow up. Or a number of times, sometimes we would, administer Narcan, they would wake up and they would just walk out. How has that model of treatment in the emergency department changed for the better from what I just described?
How it's changed for the better is that now at hospitals, the emergency medicine physician can prescribe buprenorphine after they treated someone for overdose. One thing that we observe is that sometimes following an overdose, when we give them Narcan, it throws them into withdrawal. They leave the emergency room and they're looking for heroin to ease the withdrawal symptoms. So with being able to administer buprenorphine in the emergency room, giving them a referral for treatment at a facility the same day. For example, at Howard, we have a walk-in clinic that a person who has a substance use disorder can come. They have less of a barrier to treatment and getting relief from the withdrawal symptoms. Because withdrawal is a very unpleasant physical experience.
Right. I mean, it's throwing up, diarrhea, shake, sweatiness, and it can also be life-threatening. So people that leave and immediately go look for heroin to stop those symptoms are essentially trying to medicate. So I think that's excellent news that buprenorphine, which helps to counteract those things, is available to them right then and there, so they can make a rational decision about, okay, I think I'm ready for change. I just almost died, but I don't have to deal with those symptoms right now. I can actually take advantage of the program that Dr. Scott has, or I can make that appointment to go see Dr. Bland. So, Dr. Scott, I've heard this term peer navigators.
Mhm.
What is that, and how do they fit into this process?
Oh, they are essential to this process. Peer navigators, you'll hear peer recovery specialist, peer recovery coach. There's someone who has lived experience with addiction. They could have had the disease of addiction, or they might have had family members with the disease of addiction. And they use their own recovery to support and assist others as they are going through the recovery process. They might help them to get access to treatment, navigate some of the challenges, and then just help persons to sustain their recovery.
That's wonderful.
I have a question for you, Dr. Scott. Could you tell us how I, as a loved one or a family member or someone who's close to someone who may be at risk, how can I really identify whether my loved one is at risk?
Well, what we know about, let's say, alcohol, if women drink more than 7 drinks per week or 3 drinks per occasion, that puts them at increased risk for illness or injury. For men, if they drink more than 14 drinks per week or 4 drinks per occasion, that puts them at increased risk for illness and injury. And once again, we're not saying that they might have a severe substance use disorder, but they might end up in the emergency room with a cut, or they might get into fights. So that is alcohol. As far as other medications, of course, prescribed medications, you should only use as prescribed, and not use other person's medications. And then for the marijuana and other drugs, that's pretty tricky because we can't really do studies on that. But we do know, with illegal or legal drugs, that you have to be very, very careful.
What about behaviors, though? I go back to Dr. Bland's definition earlier, where, if something is causing a functional impairment, then
Right.
you have to be concerned. So if you see somebody being late for work because of,
Right.
or not going to school, or their grades dropping, or having interpersonal relationships with their BFF or with their parents or their kids, getting into car accidents, you mentioned that, or falls, all of those are ways where it seems like your life might be unraveling, even if it's in small
Right.
ways, that might be a sign that
Yes.
Yes.
something is up.
Absolutely. Role impairment, as you said, with home, family, friends. Absolutely. Hazardous use. Absolutely.
Just to add to what Dr. Scott said about at-risk drinking, when we talk about a standard drink, we're talking about a
Mm-hmm.
12-ounce can of beer, an 8-ounce can of a malt liquor, 5 ounces of wine, or 1.5 ounces of 80 proof alcohol. So if a person is drinking 3 24-ounce cans of beer a day, that's 6 standard drinks in one day.
Wow.
So they need to know, the audience needs to know what a standard drink is.
Thank you
Right.
for the comment.
Very
And
good. And even
I can't
like,
tell you.
I was just going to say about like Long Island iced teas, if persons go out to drink, you know that's more than one drink, or a Mai
Absolutely.
Tai. And oftentimes when persons are drinking wine, as Dr. Bland said, most people don't drink 5 ounces of wine, which is considered one drink. So thanks for bringing that up, Dr. Bland.
Yeah, thank you, Dr. Bland. And I can't tell you how many times in the emergency department I could smell the smell of alcohol on somebody, ask them, have you had any liquor today? They'll say no. And I'll say, well, what is that I smell? They say, well, I had some beers. People
Yeah.
don't think of beer as alcohol, right? And so that's really important to define that, as well as the difference in genders, because like you mentioned, the difference is different for men versus women, because women don't have enough of the enzyme that breaks down alcohol. They don't have the same levels as men. So it's not sexist. It's actually biological. I can't believe we have so many things to talk about, but I want to make sure we get the audience questions in. And so I'm going to invite Wayne and Lila to come on back and join us and see if we have any questions or comments from the audience that we need to jump into and have our esteemed guests answer for us. Wayne, Lila.
It's an incredible show. Go ahead, Lila.
Really, really good show. This is for anyone who can answer, but for those folks in need and have limited access to care or transportation, what resources are available to them?
In
Dr.
terms
Scott, there we go.
with limited resources, there are the federally funded, federally qualified healthcare centers. And many of those centers will take uninsured and underinsured persons. So they are still places that they can seek and receive treatment at.
Thank you.
Mhm.
I also wanted to add to that, for people on Medicaid in many places, they should check their benefits, because their benefits can entitle them to transportation, as well as Medicare benefits. For example, if you have a Medicare Advantage plan, that might also entitle you to certain transportation benefits to get back and forth from the doctor, as well as telehealth for people who also don't have transportation as well. So check your benefits, if you have Medicaid or Medicare.
All right. We have a question coming from TT on YouTube. Hey, TT. Do we really know the health effects of marijuana use, even in small amounts? Meaning, is there enough empirical data to support that even a small amounts of marijuana is safe?
Great question, TT.
That is a great question. And right now, we don't know
We don't.
what's a safe amount of marijuana to use. because it's going to vary on individual factors. Unlike with alcohol, we've pretty much established that that amount which is put a person's at risk for developing a alcohol use disorder. We do not know that from marijuana.
Wow.
Okay.
And that's because our bodies break down marijuana in different ways.
Mm-hmm.
Right. So it would vary. And I think that's part of the concern about legalizing it before we know that information, right?
Mhm.
And then also, we do not know the potency of the marijuana.
Right.
And that's the regulation question, isn't it?
We have a certainty that alcohol, unless it's grain alcohol, is usually 80 proof.
Right.
But there's no proof system for marijuana.
Is that the regulation question you were referring to before, Dr.?
Yeah, it's increased over the decades too.
Yes.
The THC
Right.
level
It's
has
more
increased
potent.
significantly.
Mhm.
So we have a question coming from DJ Lance Reynolds. What's the panel's opinions on the new drugs, quote unquote drugs, chemical food additives that create an addiction to certain products that, much like drugs on the federal schedule, can cause mental and physical harm? Additionally, has any attention been given to sugar and milk addictions that lead to obesity and its related issues? That's a mouthful, Lance. Go ahead.
It is.
And
Dr. Bland, you want to take a stab at that?
Yeah.
I'll take a stab at it. I'm not aware of any double-blind studies looking at the effects of sugar, but we know that food in and of itself can be addictive. That
Mhm.
people use food for various disorders, mood states, for especially some people when they're depressed, they eat a lot. Some
Right.
people when they're anxious, they eat. Some persons will eat as what they say comfort food. So we know those things occur.
Is that something that falls under your aegis or your jurisdiction?
Yeah, we will see it as an associated feature of a psychiatric condition, for example, depression or anxiety.
Got it. Thank you. Thank you for that question.
This isn't a question, but I'm going to ask you to reiterate those sort of indicators that folks might be having a problem. We just came out of that, like the 3 drinks a day or however many a week. Because listen, if we had done this show in 2020, I would be in a program.
Yeah.
Because folks around me would be like that wine every day. So I just want us to reiterate the number of drinks and like Dr. Bland said, sort of identifying what a can of beer, how many ounces, that kind of thing, because I think that's really important information.
Okay, so for a standard drink, 1 12-ounce can of beer, 1 8-ounce can of a malt liquor. So if you get a 12-ounce can of malt liquor, you really got 1.5 drinks.
Okay.
5 ounces of wine and 1.5 ounces of 80 proof alcohol. So in a bottle of wine, if it's a fifth, that's 5 standard drinks.
Okay.
I was pretty much
And
having
there's-
5 standard drinks every
And then
other day.
Go
for
ahead, Dr.
women,
Right.
if women drink more than 7 drinks per week, 3 drinks per occasion, that puts them at risk for illness or injury. And then men, more than 14 drinks per week or 4 drinks per occasion.
So I'm going to ask the elephant question. is there a way to mitigate that at the time that it's being consumed? For example, you're at a party, you're at a family reunion, you're at a gathering, okay?
Mhm.
And
Mhm.
the 3-drink or 4-drink per occasion situation is just going to be bested. Is there water or food intake, for example, that could adjust that tendency to get you? And I'm not trying to say, how can I push the limit? What I'm
Right.
trying to, I'm looking at,
Are you sure,
very
Karen?
real. Listen, I'm a lightweight. I'm really sort of left of that, but in any real situation, we're at a party, we're at a family reunion, and we're eating and we're drinking, we're eating and we're drinking, and it's all afternoon. So I'd like to hear about that, please.
Well, unfortunately, eating does not increase the number of drinks you should have.
Okay.
Your blood alcohol
Good to know.
is still going to
I
go up.
didn't want to ask that question.
So,
It doesn't soak it up, in other
yeah,
words.
Dr. Bland, it doesn't soak it up.
But
I've been using that all wrong.
no, you're still at
You mean
risk
eating a loaf
for
of bread
getting down,
as you
driving
drink?
under the
You said
influence,
bread.
driving while intoxicated.
Okay.
If you drink more than the recommended amount. And what Dr. Scott talked about, 3 or more drinks, that's what we consider as binge drinking. 4 more drinks for men, that's binge drinking. And alcohol, some people don't know, but alcohol can kill. You can die from alcohol overdose.
Absolutely.
It's a respiratory depressant, so it can kill.
So,
Yes.
and go ahead, Dr.
Wayne.
Mill.
Go
Go ahead,
ahead.
Dr. Mill. I just want to know, and I guess this is for Dr. Scott. Have you noticed any trends, right, in substance abuse? People who you've dealt with, is it trending younger? Is it trending more male? Is it trending more women or young people? Or
Are you saying substance use
yes,
or at-risk use? I would definitely say marijuana has definitely increased significantly. Alcohol. Go ahead.
Go ahead. What about whether it's male or female, younger, older? What's the trend
Demographics.
there? Demographics.
The demographics. I would say that we find that what we're finding a little bit more in the DC area with opioid use disorder, that it's older men that are having opioid use disorder. Am I correct, Dr. Bland?
You're correct.
And are overdosing with it.
Oh, wow.
Yeah.
Wow.
And a lot of that has to do with the fentanyl.
Oh.
Okay. So, but as far as use, I would say it's pretty even, and it changes because life happens. And one year I might not be drinking as much, but you got COVID-19, and here we go. So that's how come with our program we try to screen everyone annually, because we know that life happens and substance use may change.
So it could be situational stuff.
Absolutely.
Okay.
Yes.
Yeah.
Right. But situational stuff might be what, leads to eventual dysfunction and health effects, etc. And I'm glad you brought up COVID-19. I'm glad you brought up the family reunion because, again, sometimes when we're isolated, we drink. When we're having a good time, we drink.
Right.
We get a lot of messages where it sort of normalizes it, especially for women. We did a whole show, right, on the normalization of alcohol use for women, drinking on certain morning shows, from that to, girls trip. And, it just sort of, and I'm not a teetotaler or preaching abstinence, but just realizing that we get a lot of messages that make it say, oh, it's okay to drink excessively or to have those 3 drinks, to wind down in the evening. and without the sort of balancing message of, hey, it could lead to health problems. So do we have time for one more question?
One more question.
Wayne? All
One more
right.
question. Yvonne Smith asks, is it illegal to be a drug addict? I see in the community and in my building people who are not aware they're addicts. Is it illegal? Illegal.
Is it illegal?
Yes, I'm sorry. I'm from Washington, D.C., North Carolina. So you might get,
you know, certain substances are illegal, but to be an addict is not illegal.
Right.
Thank you.
It's a health condition that requires treatment.
Right.
Condition,
Absolutely.
but that's not illegal. But if you're found with the substance, you can be charged with possession.
It's a very nuanced question.
Yeah.
Right. Yeah. Thank you, Yvonne. Yvonne always brings us some great questions. And I think that's it for us. Thank you so much, Dr. Bland. Thank you so much, Dr. Scott. Really appreciate your wisdom and your expertise. Karen, as always, thank you for helping us put together a fantastic show. And as always, my co-host and producer, Wayne Bruce, Lila Mays, thank you so much. Thank you to the Be Health Empowered family. Y'all always come through with fantastic questions and comments. Keep it up, keep it going in the chat. And we're gonna go ahead and sign off now. If I don't see you within the next week, remember, be wise, be well, and be health empowered. Thanks for joining.